My patient is a 67 years old gentleman who's a farmer by occupation, resident of Jodhpur. Known case of hypertension, type 2 diabetes, coronary artery disease, status post CABG running 2015, and known case of chronic obstructive pulmonary disease, who presented with chief complaints of constipation for 3 months and bleeding per rectum for 3 months. History of presenting illness. Patient was apparently asymptomatic 3 months ago, after which he developed constipation for 3 months, passing hard stools once in 2 to 3 days. I would like to know if there was any associated history of secretion of mucus and worsening of the constipation and the progression of the constipation for the past 3 months. He also complains of bleeding per rectum during defecation. I would like to know if it is a painful or a painless bleeding, what kind of bleeding it is, whether it is fresh red blood or altered blood, and is there any history of passage of clots? Is it separate from the stools or mixed with stools? The patient also complains of passage of blood and urine for past 3 days associated with burning micturition. He was evaluated for the same in an outside hospital and underwent colonoscopy and CECT. Uh, I would like to know the findings of the investigations. There is no history of abdominal distension or spurious diarrhea. I'd like to know if there is any history of sensation of incomplete evacuation. No history of jaundice, itching, perianal pain, discharge or swelling, mass per rectum, night sweats, urinary disturbances, fecal urea or frequency. Uh, I'd like to know if is there any past history of hesitancy, poor stream, dribbling of urine, or pain during micturition. Incontinence of there is no history of incontinence of stools or urine. There is no history of breathlessness, headache, and bony pains. I'd like to know if there was any history of loss of weight or appetite. Past medical history. Patient is a known case of hypertension, type 2 diabetes mellitus, and coronary artery disease since 2015, and he underwent coronary artery bypass graft in 2015, and is a known case of chronic obstructive pulmonary disease. I'd like to know what medications he is currently on for these comorbidities. There is no history of thyroid disease or tuberculosis. No past surgical abdominal history apart from the CABG done in 2015. There is no similar history in family members. Personal history, the patient does not have any addictions. He takes a mixed diet, appetite is reduced, and sleep is reduced.
So hello, can you hear me?
Yes, sir, I can. Sir, when I cannot see you, sir. I just.
Is this your first presentation in
Yes, sir.
any forum,
Yes, sir.
or you have been presenting in clinical case presentation in your institute?
No, sir.
Ah,
In the institute, I have been presenting, but in a forum online, it is first.
okay. See, when you are presenting case, you need not say that I would like to obtain these histories, I would like to obtain that histories. That's a wastage of time. Where here we need to know exactly what is the history. So you have to say that these are the positive histories, these are the negative histories, like that, rather than what you want to see. So what you that you have already seen. So you have to tell what you have seen. Okay. So I would like to see these things, not necessary. So before the clinical examination, so you have presented the history. What is the summary of your history? Summarize the positive and negative points of your history, which would point towards your diagnosis.
My patient is a 67-year-old gentleman who is a known case of coronary artery disease, status post coronary artery bypass graft done in 2015, and known case of COPD and diabetes mellitus, who presented with 3 months history of constipation associated with bleeding for rectum and associated with hematuria.
So with any significant family history or something, you have to say without any significant family history, treatment history, or any past history. And with that, any significant bowel or bladder symptoms if it is there. If it is not there, also they have to be included as the important negative history in the summary. So with this summary, Dr. Kalai, please ask your questions. Then I.
Yeah. So what's your thought process when you have this history? What a differential diagnosis at this stage?
I'm suspecting a left-sided colonic or rectal lesion in this patient, sir. Considering the age of the patient, neoplastic malignant etiology is my first differential. And second, although unlikely, it can be a presentation of inflammatory bowel disease.
Okay. What do you think of inflammatory bowel disease?
Just to keep as a second differential, sir. Otherwise, my first differential is.
No, I agree. The first
etiology.
differential, I agree. But what point in the history made you to think of inflammatory bowel disease?
Alteration of the bowel habits with bleeding per rectum. Similar symptoms can be there in ulcerative colitis, which is involving the rectum or the left side of the colon.
No,
But although this age group is not common for this kind of presentation, not common for ulcerative colitis.
no. As per the history, it is constipation, right? He had constipation.
Yes, sir.
So how often you have seen a patient with ulcerative colitis presenting with constipation?
Very less frequently. Usually, it is alteration of diarrhea and constipation, altered bowel habits, sir.
See, the typical symptom is increased frequency, right? So you don't, that is a late stage. If they develop some stricture, okay, which is again very unlikely in less common hepatitis. So even if you want to have some differential diagnosis, it should not be inflammatory bowel disease based on this history. You can even keep, what else you'll think? You just imagine you are sitting in OPD, patient coming with this complaints. As you mentioned, yes, you will keep the malignancy as a first diagnosis. Anything else?
I can also think of internal hemorrhoids in this patient, sir. Constipation associated with painless bleeding per rectum can be a symptom of internal hemorrhoids as well.
Okay. So how will you explain you didn't consider the bleeding while passing urine?
Sir,
Hematuria,
I'm
right?
unable to hear you.
Okay. The hematuria was the another presenting symptom in this patient, right?
Yes,
So
sir.
you don't want to take that into consideration in your differential diagnosis?
Uh, like it will be part of the, can be, my thought process is it can be a part of the neoplasm uh, suspected malignancy, which is might be infiltrating if involving the prostate or something. So that's why that is the first differential along with the history of hematuria. But in the second differential, it is not fitting in the internal hemorrhoids.
Any other benign pathology can have this type of constipation and then some urinary symptoms. Less common, but you had hemorrhoids.
Recto-urethral fistula might present this way, but there is no other
No,
contributing.
diverticular disease, can you present like this?
Diverticular disease and chronic constipation, it can present sir, with no bleeding.
Can they also have bleeding?
Uh, it will be, yes, sir, they can have bleeding. Okay.
So, I mean, the point is when you have different diagnosis, it's better to tell not for the just purpose of giving a differential diagnosis. I don't think inflammatory bowel disease will nowhere come fit into any of your symptomatology. Even if you want to tell inflammatory bowel disease, you can tell maybe Crohn's colitis at least, but not definitely ulcerative colitis with this symptomatology. Just think about what other conditions can you explain all the symptoms this patient is having. Okay.
And carrying forward, see, when you these type of cases when you are getting, you have to know what are the causes of bleeding PR. That's a natural question from the exam. And if I analyze your case at this stage, I would divide it into three parts. One, what are the local causes, and what are the generalized causes, and what the causes which can cause bleeding PR as well as bleeding per urethra. So, what are the local causes of that? Again, this is divided into two parts. You may be asked about obstruction with bleeding, bleeding without obstruction. Let's not discuss bleeding without obstruction like ischemic colitis and others, how to differentiate. So, bleeding with obstruction, local causes could be hemorrhoid, could be fecal impaction. All these are possible. Chronic constipation due to neurological causes, poor motility. All these are very common in elderly age group, even if it is 3 months duration. And apart from these serious local conditions like strictures, tuberculosis, malignancies, local venereal infections causing strictures, these are also, they can come into picture. Generalized conditions or even angiodysplasias can come, but they are not associated with stricturous lesions. And generalized causes, what they could be in this particular case, they are very important. They are also important when you say causes of bladder as well as bowel involvement. Like for example, this is a patient who has CABG. So drugs causing bleeding. Are easy taking them. So what are the causes of bleeding per urethra as well as from the rectum? In this patient, 67-year-old who has CABG. So what are the causes of bleeding from both the sides? One is generalized coagulopathy, severe infections, vascular disorders, warm schistosomiasis, which is not common in India, trauma, and of course, in this case, it would be important if it has an advanced malignancy. What malignancy will cause bleeding from both the areas? And even large stone of bladder can erode and cause bleeding. Those are also described. Those are very, very rare. But which malignancy will cause bleeding from the rectum as well as bladder?
Colorectal malignancy will cause bleeding from rectum as well as bladder.
Suppose a malignancy is from
Bladder cancer.
colorectal as well as involving the rectum as well as bladder.
Bladder.
How do we know which is the hen and which is the egg?
Like we can understand by the progression of the symptoms, sir. The natural course of the disease. If major complaints were related to the genitourinary system, then the primary pathology might be in the urinary tract and then secondary involvement of the rectum. Or if the primary complications of the patients were more related to the gastrointestinal
There are no specific complaint. When it is affecting both, you'll get both the things. But mostly, roughly, you can say the symptoms would be more common of that area and would come earlier than the other one, isn't it? So if a person has hematuria and then later on having rectal bleeding, so possibly that there is usually a conflict when you get this type of cases with urologists. So who will take up this case? So there are so many things possible, including malignancy. And you must remember, in this case, I will never ever keep ulcerative colitis as the first diagnosis, as you said. 67-year male, what is the definition? More than 60 years, first onset of symptom. If it is bleeding or this, think about malignancy. First, exclude other than this. Okay. So, Kalai, can we go to the
Yeah, we'll go to
examination?
examination.
Examination, please.
Yes, sir.
Only positive and significant negative.
In the general physical examination, the patient is conscious, cooperative, and oriented to time, place, and person, moderately built and poorly nourished. With ECA performance status has not been given to me, sir. With an normal BMI of 27.2, uh, there is no any his vitals are stable. There is no any evidence of pallor, icterus, lymphadenopathy, or pedal edema. No signs of dehydration. Oral cavity examination is normal. There are no skin lesions. The per abdominal examination is essentially normal on inspection and palpation. There is no palpable cuff impulse. The percussion and auscultatory findings are also normal. On digital rectal examination, the perianal skin appears normal with no fissure, swelling, fistula, hemorrhoids, or discharge. The sphincter tone is normal. The circumferential ulceration is noted with friable granular mucosa noted 5 centimeter above the anal verge, and its upper extent is not reached. On the glove is stained with blood on the digital rectal examination. Rest of the systemic examination is essentially normal, sir.
Yes, sir.
So now you have the diagnosis?
Yes, sir. Based on the based on the examination findings, I'd like to keep my diagnosis as a neoplastic lesion of the rectum, most likely a carcinoma rectum, sir. My first differential diagnosis.
Okay. Yeah, can you rule out the CA bladder with rectal involvement?
I cannot rule out CA bladder with rectal involvement in this patient, sir.
Okay.
Suppose the growth is specifically 2.5 centimeter growth, posterior wall of the rectum fixed to the sacrum. Is it from the bladder?
If it is located on the posterior wall, sir, and anteriorly the rectal mucosa is free, then there is a possibility that there might be a separate growth which is in the
No, is
bladder.
it possible the bladder can involve only the posterior wall of the rectum 2.5 centimeter?
It's unlikely, sir, that a
So
2.5
those are,
centimeters
see, you
should.
have to answer something. It may be very, very rare or something, whatever.
It is
So
unlikely.
you have to show your thought process that yes or no, if that isn't where it is. So it's only cancer. Can it be tuberculosis?
Like tuberculosis of the rectum, this kind of presentation is unlikely, sir. I have not
What is
seen
the normal, what is
such
the
presentation.
usual involvement? You know or not? What is the usual involvement character of tuberculous proctitis? Is it mass? It is texture? It is just bleeding? If you know, say yes. Because we can't discuss everything.
I'm not exactly sure, sir.
Can you exclude lymphogangloma venereum?
There are no any lesions on the perianal skin, sir. No warts, and no lymphadenopathy localized also. Uh,
Can you
so,
exclude a Kaposi sarcoma?
uh, Kaposi sarcoma is usually seen in patients who are HIV positive, sir. But this patient has not given such kind of a history. So it's unlikely that this patient is having Kaposi
No,
sarcoma.
question was whether now we're discussing about the local examination. So by examining the tumor, can you exclude all these things?
Lymphogranuloma venereum I can exclude based on no evidence of lymphadenopathy, a painless lesion, and
Lymphogangloma involvement of STD involvement of the rectum, the ulcerations and the mass formation. What is the difference? So that you have to know for differentiating in the local examination. So similarly, so you have to say whether it is malignancy or it is some benign lesions, like which benign lesion can mimic the cancer rectum.
solitary rectal ulcer syndrome can make.
It can mimic, but it's very difficult to palpate. It's usually at the rectosigmoid junction. The finger can't go. Yes, it can. What else? What about villous adenomas?
Yes.
So
Large
this one,
polypoid adenomas can have
polypoid with excrescences. Simple polyp definitely will be able to differentiate. Sessile polyps difficult to differentiate. What is a DALM? DALM?
disappearing liver metastasis.
No, 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 no. It occurs in ulcerative colitis. You have any idea? Okay, so there could be many differential diagnosis, local examination of the tumor. So your thing is, you are saying it is 5 centimeter above the anal walls, isn't it? And anything else you should have told about the examination for the so far as the tumor is concerned?
It has been mentioned that the tumor is circumferential in extent and 5 centimeter from the anal walls with normal sphincter tone, sir.
Mm. So you have to say whether you are able to reach the upper limit and
Upper
lower limit.
extent had not been reached.
So upper extent has not been reached. So it could be that the tumor has extended up to 10 centimeter. Possible, not possible.
Yes, possible.
So how do you say it is upper rectum, middle rectum, or lower third rectum? Suppose the tumor starts at 5 centimeter, goes up to 10 centimeter. How do you explain which site it is, upper third, middle third, lower third? Because the management differs.
Usually for the management part, we will consider the lower extent of the tumor because the distal resection margin will be decided based on the lower
Correct,
extent.
correct. So it's the lower extent which decides whether it's upper, middle, or lower third. And you should have told about lymphadenopathy, which I asked, then you said from the examination, general examination. Okay, so we are in a situation now. There is a tumor unpassable 5 centimeter from the anal walls, fixed or non-fixed. Suppose let's see that it is not fixed, and we are not able to reach the upper end with no lymphadenopathy. Kalai, you want to ask any other question regarding examination or next step?
No, I think we can proceed, sir.
Yes, please. Then please ask.
So, how would you like to proceed in this case, sir?
First, I'd like to review the old investigations and records of this patient, sir, as he has been evaluated outside. In the history, he told that there was an endoscopic procedure done, colonoscopy has
So you
been
can
done.
tell in what order you want the investigations. Will tell you the findings.
I'd like to have two sets of investigations, sir. First to confirm, I would like to review the old investigations, then two sets of investigations. First to establish the general physical condition of the patient, a baseline set of investigations, and second set is to confirm my diagnosis. So first, I would like to review if any previous blood investigations are available, and what was the colonoscopy report of the patient, and if any biopsy has been done, and if that report is available at that time.
Okay, so the colonoscopy revealed ulceroproliferative growth at distal rectum, and the biopsy was taken. Biopsy was suggestive of adenocarcinoma. So the scope passed beyond, and there are two polyps in sigmoid colon, and one polyp in rectosigmoid region. No other polyps elsewhere. Okay, and the biopsy from the polyp is adenomatous polyp, right? So that's the colonoscopy finding. What else you wanted?
Uh, the scope is negotiable across the entire colon has been seen and no any other lesion.
So there were two polyps in sigmoid colon and one polyp in the rectosigmoid region. And biopsy taken from the polyp. Upper extent of the growth.
Yes, sir.
Yeah, so that was not mentioned. So they just mentioned there's a large ulceroproliferative growth in the distal rectum. And distance
of the growth from the anal word, sir.
So that's also not mentioned.
Okay.
So you are more interested in finding the distance from the colonoscopy or from your clinical examination in this case?
Both, sir. I would like.
No, with a clinical examination, where was the growth? Lower
5
extent.
centimeters from
So
the
is that clinical examination more reliable or colonoscopy?
In colonoscopy, there is a marking on the colonoscope surface, so we can get an
Hey, come on.
exact.
So it's not a difficult. Don't think too much. So it's such a straightforward question. So why you want to get yourself into trouble? So you want to something which you can feel with your finger. So you want to
Clinical
the distance
examination.
with the colonoscope, which you know there is obvious problems. It's a flexible colonoscope. It can bend.
And yes.
Okay, so when the question is straightforward, you should just pick up the clue and then give the answer quickly. Otherwise, unnecessarily you will get wasting time, 5 minutes in this.
I'd also like to know the other blood investigations of this patient, sir, and if any tumor markers were sent.
So specifically in the hemogram, there's no anemia. Okay, hemoglobin is 13, and liver function test essentially normal with albumin of 3.8. Renal functions normal, creatinine 0.9. Any other blood investigation you are specifically?
I'd like to know the viral markers of this patient, sir, HIV, HBsAg,
Negative.
HCV, and tumor markers of this patient. Sir.
No, what? You should not tell tumor markers. There are so many tumor markers.
CEA levels for this patient. Sorry.
2.33.
Okay. Um, Next, I would like to evaluate this patient further, sir.
Yeah, go ahead.
I'd like to get an ultrasound abdomen. I'd like to get an abdominal X-ray and an ultrasound abdomen done for this patient, sir.
Why abdomen X-ray?
I'd like to, because he's having chronic constipation, I want to know whether he's in any kind of subacute intestinal obstruction
Okay.
and to rule out any dilated bowel loops and treat as such. Sir. And then ultrasound examination to look for any free fluid in the abdomen, to look for any regions in the liver, sir, and to look for any omental deposits or thickening or peritoneal deposits if can be seen on the ultrasound.
If you are taking abdomen X-ray, something else also you will combine?
Now, obstruction, dilated loops, sir, and
In a rectal growth, lower rectum, 5 centimeter. You are sending the patient to X-ray room for abdomen X-ray. Anything else?
chest X-ray along with the abdominal X-rays.
What is the idea behind? So if you on clinical examination you are finding no evidence of any obstruction, still you go ahead with abdominal X-ray?
Like
In a constipation patient, his abdominal X-ray is so indicative. It will be fecal matter everywhere. Does the guidelines say that you should have a abdominal X-ray where you are suspecting rectal malignancy?
no, sir. Just because of
So
the
you have done
symptoms.
a biopsy. What do you want to see?
Sorry, sir.
You have done a biopsy. Colonoscopy, you said you'll do, and obviously you'll do a biopsy or no biopsy.
Biopsy has been done, sir. Told adenocarcinoma.
Adenocarcinoma. Anything else you want to see in the biopsy? Should you see for differentiation and other features in biopsy at this stage?
I can, yes, sir. I would like to see.
How does it differ your management now?
I'll just know the biology of the tumor, sir, by knowing the kind of differentiation
How
it
does
is.
it differ your management now?
It will not change. It will not affect unless I'm done the local staging of the disease or evaluated the patient further.
So my question is, at biopsy nature or differentiation at this stage can affect your management or not? Cannot affect.
No.
So the answer is it will affect my management, but it depends upon what would be the stage for the disease and the site for the disease. So if the biopsy is well differentiated, my margin of resection will be less, even 2-3 centimeter. If it is not, it becomes 5 centimeter. So you should know why you are doing that. Now tell me, if the biopsy says it is mucin secreting adenocarcinoma, you must have seen mucin secreting adenocarcinoma. What does that mean? Is it a grave? It's a high biology. It's a good biology or bad biology, or
No,
it
sir.
has some connotation on the management.
It's a poor biology tumor, which is a mucin secreting adenocarcinoma usually.
So if it says it is a signature carcinoma,
Signating carcinoma is also a poor biology tumor, sir,
what is the
because
difference between signated ring cell carcinoma and mucin secreting cell carcinoma? Are they same or different?
no, sir, they are different, but exact
How?
difference I'm not sure.
So one is a extracellular mucin, which is a mucin
Mucin
secreting one. One is the intracellular mucin. The intracellular mucin signating
signating
cell
cell.
is much more dangerous and aggressive than extracellular mucin, and it has a bearing in your management. So whatever you are doing, you should know exactly what things you are going to do. Do you want to do any markers at this stage from the biopsy tissue? Is it recommended, the guideline?
In the NCCN guidelines, they have recommended in the initial colonoscopy and biopsy to do uh, MSI testing for a rectal
That's
malignancy.
what you have to answer. Apart from the biopsy, just knowing that it is this, I would like to know these things. So this is the status of the patient. Well difference it is there. So I will review the biopsy for further differentiation so that I can correlate with the staging. So that's the thing. Why you are searching for the chest, the abdomen, the liver, all these things in the patient examination? What is the significance? You are
Uh,
expecting metastasis, isn't it? That's why you are checking. Plus any other concomitant disease.
yes.
What are the incidences of metastasis in lungs, liver, bone in case of cancer rectum? So if it is 0.001%, then I will not look for. I will not look for adrenal metastasis. So I would definitely look for chest. So no, it's if you just roughly divide, it is 15, 10, 5, and 1. So 15 is, what is the maximum? Is liver. Then
Liver most common, sir. Then
lungs.
liver.
Then 7 or 5 is bone. Then 1% rest of the things. So those are the explanation why you should go for studying different distant metastasis in this patients. Okay, next. Dr. Kalai, please.
Okay. So, how do you want to proceed next?
I would like to do imaging of this patient, sir. I'd like to get a MRI pelvis done for local staging, and I would like to do CT chest and CT or MR abdomen for staging the rest of the abdomen and chest.
Yeah. So obviously, see, CT or MR abdomen. What do you prefer?
In our center, we're usually doing CT abdomen with CT chest, sir. But both can be done. MRI abdomen with MRI pelvis and CT chest for the chest parts.
Now, why that is not commonly performed? MRI abdomen with MRI pelvis.
Because because of factors like it is more time consuming and the availability of CT is more easily available in faster investigation than MRI. CT abdomen is more convenient and uh, technically more easier to perform. So CT
Yeah,
abdomen is
because
preferred.
you know that, no? So the acquisition, the sequences are different between pelvis and abdomen.
Abdomen,
You're
yes,
going to
sir.
combine, then it's going to take a long time.
Long
Plus,
time,
also
yes.
you need to remember that when these patients are followed up, it's always you repeat the investigation which was
CT,
done earlier. So every time you won't be doing an MR abdomen, no, during the follow-up.
yes,
So that's the reason why commonly MR pelvis is combined with the CT chest and abdomen,
yes,
because you repeat the same investigations during the follow-up.
yes,
So I think you have the imaging with you, right? This
yes,
patient.
sir.
So you can
Yes,
just share the MR pelvis and then read it.
okay, sir.
Till the time you show that this is a stock question here in examination. The guidelines say that you should do a MRI pelvis or lower part of the abdomen and rest is CT scan. So you must be able to answer this one on the basis of evidence or sensitivity or specificity. MRI has a very, very poor sensitivity, specificity in comparison to CT so far as the chest metastasis is concerned. So those are the areas where CT is very, very helpful. And in comparison to that, if you look at the pelvis, the sensitivity of the CT scan is about 80% in comparison to 95 to 100% in case of MRI. MRI can show you MBIs, EMBIs, more about the mesorectal fascia, the mesorectal tissue, and small lymph nodes in comparison to the CT. And MRI also is a good investigation in the follow-up to know the response. These are the answer to that question. Okay, please tell us the findings.
Sir, can you see my screen, sir?
Yeah, we can see.
Yes.
So this MRI is loading, sir.
Okay. So I think which is loaded? CT is loaded?
CT is loaded, sir. Yes.
Yeah, you open the CT.
Okay, sir. This is the skygram of patient Mahendra Mathur done on at our outside center, extending from the lower part of the chest to the mid thigh level, which is showing prominent, like a normal gas shadows with a dilated bowel loop in the center of the abdomen. The CT is open, sir. Can I open? MR is ready, sir. The MRI, in the MRI,
So you show us in the line of guidelines the MRI pelvis findings and CT abdominal and chest findings.
yes. First, in the MRI, first in the sagittal section, I would like to localize the tumor and its extent from the anal verge, sir. So in this patient, a contrast enhanced contrast is given, sir. And in the MRI, there is a irregular circumferential thickening of the anterior wall of the rectum, sir, which is extending from.
So how you decide the lower X? You
Sorry,
started
sir?
one point, right? Which point you have selected for measuring the distance?
From the anal verge, sir. From here, I would like to start.
So how you know anal verge?
The gluteal fat and the muscle region are ending over there, sir. And the anal verge is beginning the depression in the.
So is that a commonly used? Your radiologists commonly use that as a point for the anal verge?
Yes, sir.
Any other landmark which has been used?
The anorectal junction can be used from the inferior border of the pubic symphysis to the inferior border of the coccyx bone, sir. That is the anorectal junction, below which is the anus and above which is the rectum, sir.
So the point where the internal sphincter ends, is there any?
The presence of levator ani, the puborectalis sling and the levator ani, where they.
No. What I'm asking is, one of the landmark that is used is where the internal sphincter ends and the intersphincter groove. Okay, proceed.
So approximately 7 centimeter from the anal verge, in the anterior wall of the rectum, there is irregular circumferential hypointense thickening, sir, which is seen extending till the upper part of the rectum. And in the coronal plane, sir.
You have to answer like this. What is the extent of the growth along the rectum? What is the circumferential extent? And then the mesorectum the vascular structures nearby and the
Yes,
lymph
sir.
node post
Yes.
this. So first you said extend, and quickly let us tell what are the, let us say we need to know about the circumferential involvement and the mesorectum. So was the mesorectum, whether it is involved or not involved.
Yes, sir. So in the axial section, I will look for the mesorectal involvement, sir. So this is the rectum. This is the irregular circumferential growth, sir. And the mesorectal fascia around it, there is loss, hypointensity in the anterior part of the rectum, sir, here, with mesorectal involvement, sir. And there seems to be some infiltration into the seminal vesicles as well, and some cystic lesion in the right seminal vesicle also. And
What about the blood?
No,
Because the
I,
patient was having hematuria.
yes, sir. Yes, sir.
That you have to comment.
The here, sir, anteriorly the fat planes with the prostate are not very well differentiated, sir. So
What about bladder?
also, bladder in the lower part,
Okay, let's say that the fat plane with the bladder and the
in here
prostate,
also,
we
sir,
are not able to differentiate it. Let's go
not
over to
able to
the
differentiate.
nodes.
Sir, I can see
Where are the nodes? Show
some
me one
dilated.
significant node. And what is that blackish thing at 7 o'clock position?
Here, sir.
Go on, move one up and down.
These are dilated vessels, sir.
What is
Suggestive
this?
of
What is this?
this is a perirectal node, sir.
Quickly tell.
yeah,
Can
what
you?
else you'll comment? So you commented about
The
mesorectum.
mesorectal fascia is involved anteriorly, sir. In the circumferential resection margins, there are multiple lymph nodes in the circumferential resection margin is also threatened. There are enlarged lymph nodes, sir, in the perirectal area, and some dilated ectatic vessels. I can see this is the black spot, the vessel, and it is dilated and ectatic, sir. So this is suggestive of extramural venous invasion, sir. Vascular invasion,
Vascular.
EMVI.
Okay, let's stop it here. And this is the situation. What are you going to do? So we are at a situation where the growth starts at 5 centimeters circumferential, goes over to 10 centimeter of rectum, and plane between bladder and the growth is not very discernible on imaging, with few mesorectal nodes and vascular invasion,
Yes, sir.
extramural vascular invasion. So what is the or venous invasion? So what is to be done now?
I would also like to review the CT abdomen, sir. I want to
Okay,
see if
CT
there
did
are
not show any discernment.
liver
Yes.
metastasis or no.
So there's no metastasis. Now tell us to do.
Based on this imaging, sir, this is a locally advanced rectal cancer, sir.
No, anything else you want to evaluate in this patient?
Because there is suspicion of bladder involvement, I would also like to get a urology review and get this patient evaluated by doing a cystoscopy. And I'd like to see if there is any bladder mucosa infiltration or involvement, sir. I'd like to document it for the purpose of hematuria. Also, I'd like to evaluate is there any urethral involvement or prostate
Cystoscopy did not
involvement.
show any bladder involvement. I mean, there's no mucosal. That's what you see, no? Right?
And if there is presence of any any hydroelectronephrosis on
No,
the CT abdomen, I'd like to see, sir.
not there.
So essentially, this will be a
Let's
case
think
of
that
local.
the bladder is not involved. Okay, now let's proceed.
So that means that this is a locally advanced rectal cancer, sir. with CRM involvement and EMVI involvement with node positive disease. I'd like to start this patient. Like my plan of action will be total neoadjuvant therapy for this patient, sir, for now. Total neoadjuvant therapy followed by restaging. After completion of the total neoadjuvant, I'd like to give consolidation chemoradiotherapy to this patient, followed by
Okay, why total neoadjuvant? Why not conventional long course chemoradiotherapy?
total neoadjuvant therapy compared to conventional long course chemoradiotherapy has shown a higher pathological complete response rates. I would like to go ahead with total neoadjuvant therapy for these patients.
So your aim is to achieve pathological complete response in this case.
Pathological and clinical complete response as well, both. I would like to downstage the disease first, so I would like to give a total neoadjuvant therapy to this patient.
So how total neoadjuvant therapy improved the pathological complete response?
The whatever data we have from the trials, the Prodigy 23 and the Stellar trial, they have shown a statistically significant difference in pathological complete response rate of 14 versus 28% in the Stellar and 12 versus 28% in the Prodigy 23 trial. It has. I'd like to give a TNT to this patient.
So total neoadjuvant, there are various protocols. So what you are going to use in this patient?
I'd like to give a consolidation chemoradiotherapy to this patient, sir. A consolidation, first 6 cycles of K-POX to this patient, consolidation chemotherapy, followed by short course chemoradiotherapy, and then total mesorectal excision. Then I'd like to restage the disease and then plan for surgery.
So what, this is what regimen?
Sorry, sir?
What do you mean by consolidation chemotherapy?
I'd like to give 6 cycles of K-POX, 6 cycles of K-POX or FOLFOX to this patient, sir.
So you are going to start with chemo.
I'm going to start with chemo, yes, sir.
So is that a consolidation chemo?
Sorry, sir. I'd like to start with radio, concurrent capecitabine and short course radiotherapy, then chemotherapy, and then so that is a consolidation.
No, why short course chemoradiotherapy in this patient?
That is the.
So this is which, this is, you are telling which regimen? No, you mentioned so many trials. No, so the regime, what you are telling, you are going to start with short course. You are going to start with short course radiotherapy.
Yes, sir.
And then you want to give chemo.
Concomitant chemoradiotherapy, sir, followed by consolidation chemotherapy and then surgery.
Oh, see, you need to be clear.
You have to be very clear.
Yeah.
Number one, it's not the simplest manner in which you said that total neoadjuvant therapy is better than this. The standard one, you should be able to tell us in which situation, what are the subjects, and you must know what are the utilities of short course radiotherapy, standard course, and the dose in a total neoadjuvant therapy. And you should be able to know different regimen, what is consolidation, what is starting, what is maintenance. These are very important. They are a lengthy discussion again. So we have given neoadjuvant, and you should know exactly the duration and when to do the imaging during the duration of the therapy. Now, after that, we find now the tumor has shrunken a bit. There is partial response, which is in this case, what to do?
I would like to restage the disease, sir, with an MRI pelvis.
Obviously, when I'm saying partial response and all these are on the basis of restaging, isn't it? So what to do now? There is no metastasis, there is partial response.
With partial response and no metastasis, sir, I would like to proceed to total mesorectal excision for this patient, sir. I'd like to do a low anterior resection for this patient. Ultra low anterior resection for these patients.
There was some seminal vesicle involvement, right, in this case?
Yes, sir.
What about that?
So partial response, if it is free or not intraoperatively, we'll have to assess whether planes are free with the seminal vesicles or not. So if they are free, then no need to resect those. But if involved, we'll have to take the margin along with the seminal vesicles.
Okay, so it looks to be involved. So what do you do? In the MR, which you have taken pre-op, okay. So there's still the plane is not clear. There's overall reduction in the size of tumor, but with the seminal vesicle, the plane is not clear. You did restriction, diffusion restriction. Still, there is some diffusion restriction is there. So what do you do?
I'd still like to go ahead with
Go ahead with resection or no resection when you are suspecting seminal vesicle involvement.
no, sir. I'd like to go ahead with this section with seminal vesicle involvement as well.
So what do you do then? How do you want to remove the seminal vesicle, you want to remove the bladder, you want to remove the prostate along with that?
So I'd like to
You are posting this case in the OT. What you write in the OT list? Procedure.
ultra low anterior resection with ultra low.
No, stop video, stop video. Wait, two, three, yeah,
Are you able to hear us?
Hello? Yes, sir.
Yeah.
I'm able to hear you. Yes, sir. Yes, sir.
So, Kalani, better you please tell him the answer. Tell her the answer.
Yeah, so when there's seminal vesicle involvement, the question is whether you do a excenteration or you can just do only excision of the seminal vesicle.
No, sir. Excitation is not necessary. We can get away with the excision of the seminal vesicles also, sir. Ureteral involvement or trigon of the bladder involvement and extensive lateral pelvic lymph nodes involvement will push us to do a pelvic excitation, sir. But involvement of the seminal vesicle is not an indication for doing pelvic excisions. I can get away with seminal vesicle excision itself.
So you mentioned ultra low. What is the difference between ultra low and low anterior section? And why you mentioned ultra low in this case?
Because the tumor was 5 centimeter from the anal verge, and the exact distance, there is a partial response. So distal most extent, I don't know till what, whether the response is in the upper part or in the lower part, sir. And after the neoadjuvant chemo radiotherapy, I'd like to keep a resection margin of at least.
After neoadjuvant, you have done a PR. You have done a PR in the OT also. It is 5 centimeter. Same.
Okay, sir. So if it is 5 centimeters, sir, then I can get away with a low anterior section as well, because the circumference distal section margin of.
It's a unit to be clear. So what is low anterior? What is ultra low anterior?
When the anastomosis I'll doing at the lower part of the rectum is also resected, sir, and coloanal anastomosis is done, then it will be an ultra low.
Has it to do something with the length? That's what he's asking.
With how much of the length
So
of
what
the
is the
remnant?
definition of a low or a ultra low?
Less than 2 centimeter from the anal verge, and if I am having an anastomosis, sir, and the anastomosis in the coloanal region, that will be an ultra low anterior resection, sir. If I'm doing the anastomosis from the dentate line at least 2 centimeter above, that will be a low anterior resection, sir.
No. See, you have to be clear. Low anterior resection means you do colorectal anastomosis, which means the rectum is not completely removed. You do have a short segment of rectum which is left behind, and you are doing a colorectal. In ultra low, you are doing a total proctectomy. The complete rectum is removed. Okay. So you are doing transection right at the level of pelvic floor. And then you do a coloanal anastomosis.
Anastomosis, yes.
So you should be clear. And when there is a tumor at 5 centimeter, you have to do ultra low. How you get away with low anterior section? Right?
Yes.
So low anterior section is for tumor in the mid rectum. So
Mid-rectum.
once you have a tumor going into lower rectum, very close to the anorectal junction, so it has to be ultra low. Okay.
We have done a resection now, and you must know whether to. You will be asked questions whether to do a stoma, not staple, all staple. Your exams can divert to that part also. Now we have done a successful resection. The margin appears to be free, and we have a histopathology at hand, which shows, if you correlate with the imaging, it shows it's a T4 tumor, majorectal involvement is there. It is a moderately differentiated adenocarcinoma with two lymph nodes positive, as if you correlate from the imaging. Now, anything else you need before going for adjuvant therapy or no adjuvant therapy? I'm sure whether you will go for adjuvant therapy or not.
Yes, so T4 and node positive disease, I'd like to go ahead with adjuvant therapy in
But
this
you
case.
are given a total. So if you are given a total, how can you go for a adjuvant?
Um, Usually it is given only sir, adjuvant therapy also.
It's
No,
not
no.
After,
See,
you.
I think that's fair. No, you have to be clear what regime you are using. I agree. There are some in which you give adjuvant. Although the term
Yes,
total is used, you give adjuvant.
yes, sir. Yes, sir.
But I think you are not clear with the regime you are planning in this patient. Okay. See, there are too many regimes are the TNT. You need to choose which is appropriate in a particular patient. So you had this patient with a locally advanced tumor, right? Which means you want down staging in this in the
Yes, sir.
local, right?
Yes, sir. Yes, sir.
Which means in that scenario, you should not tell short course. This case, you have to go for long course radiotherapy. And whenever you're giving long course radiotherapy, the chemo you are giving along with that is just radiosensitization, right? That's
Yes, sir.
not a proper systemic chemo. So in this case, you have to give long course chemoradiotherapy. That is definitely required. Now, the question is TNT along with long course chemoradiotherapy. Right. So there are some TNT protocols with long course chemo RT.
Yes, sir.
So what is that? Which TNT regime included the long course chemo RT?
Uh, um, in the PRODIGE 23, sir, they have
Okay.
given long
Fine.
course
So, but
chemoradiotherapy.
there, what was the
Protocols.
sequence followed? Which means you start with chemo RT or you start with chemo.
Start with chemo, sir.
Right. So
Yes,
when
sir.
you decide that I want to start with chemo in a particular patient, and when you decide I want to start with the chemo RT in a particular patient.
If the systemic burden of the disease is more or like
So how will
nodal,
you know that? How will you know that? Now in this patient, is the local burden more or the systemic? It's not systemic burden. The right term is the possibility of systemic micrometastasis is high in a particular patient because you don't have obvious evidence of metastasis. The moment you have metastasis, then it's a different. In this case, you didn't have any obvious evidence of metastasis, but are there any radiological parameters which help you to
yes, sir.
determine there's high chance of systemic micrometastasis?
Micrometastasis. Yes, sir. Extramural venous invasion and circumferential dissection margin positive and a
So that's how you
big size
decide.
of the
See,
tumor.
so in a case, you have to, in a particular patient, when there are so many regimes, you have to think, what is my treatment aim? Am I going to target a systemic disease along with local control, or I'm primarily focused on local control plus systemic. Accordingly, you sequence your TNT regime, starting with the induction chemo, followed by chemo-RT, or starting with chemo-RT, followed by consolidation chemo. So you have to just explain that. That's very important, right? So the treatment is individualized based on imaging findings and the clinical findings in a particular patient.
We have
Yeah, I think
maximum 3-4 minutes left.
yes, sir. I think
So
maybe we can.
just to conclude that what are the other things you do after you get histopathology? Any other information you needed for the management? In other words, what are the receptor or chemical or tumor marker or genetic? What are the testings which are essential according to the guidelines?
I'd like to do MSI testing for this patient, sir, to know whether the disease is MMR deficient or MMR proficient, sir, MSI high or
Are they in order, or you have to do everything at the same time?
uh, usually MSI, MSH2, MSH.
What feature or information you get or you don't get in KRAS or NRAS mutation that you won't get in MSI instability or MSI test?
I'm sorry, sir,
In
I'm not
other words,
getting your question.
in KRAS mutation, what do you see? So first, everybody does the KRAS mutation. And there are 2 or 3 more which more or less give the same information that you get in KRAS mutation. So how does a KRAS mutation give you an idea which drug to give in the post-operative period? So if it is a wild type, non-mutating type, then you give,
Cetuximab and
what is that?
panitumumab.
EGFR growth receptor
EGFR
inhibitor.
inhibitors. Yes.
So that is the significance of that. So what about how does what about BRAF?
BRAF 600E mutations for patients with these mutations positive, bevacizumab is the recommended immunomodulator.
Again, they point to the EGFR receptor inhibitor, but mostly some other drug other than the cetuximab. And MSI. How does MSI decide your treatment?
So, sir, microsatellite in stable like
What do they give an idea?
it will give whether the disease there is a MSI high instability or a stable or low instability disease. Sir. So
Tell
patients with
me a
MSI,
condition. If this will come, I will give this drug. You have to see, you have to read all these things. Now, lastly, is there a testing of CEA in tumor? Does that give
is
you
there
any
a,
information? CEA.
so CA
CEA, carcinoma antigen in tumor tissue. Does it give you any information, or do you do it?
No, sir, I'm not aware. In the tumor tissue, I'm not aware.
Yeah,
Circulatory tumor
it is
tissue.
done. You've seen they were doing some other testing. They will keep the report pending, and then they say that we will do certain testing and know about that. What is that? The CEA in tumor tissue, suppose it is nil or normal. That indicates that post-operatively, very unlikely that a CEA marker would help you in prognosticate the case. Similarly, CEA case, high CEA in tumor tissue may give an idea this is a poor biological tumor. So those are the things for our knowledge. We don't do all of them. Mostly nowadays, if you go by KRAS mutation, you must know MSI mostly. And then you must know how to follow up with these patients and how to follow up the family of the patient. Okay, so I think Dr. Nag, are you there?
Yes, sir.
So please conclude.
Okay, I think Dr. Harjeet is there. If you want to say something, you can.
Doctor?
Hello,
Yeah.
sir. Good
Hi,
evening.
good afternoon. Good afternoon.
Good afternoon, sir.
You are there. I would have
Yeah.
involved you more in the discussion.
No, it's okay. So I think the only thing which I
So
want to tell is that
you are in the earth or outside the earth?
no, sir. Some background is like this. I don't know how did.
Oh,
I'm on the
it's
earth only.
okay.
So I think the one important thing is she in from the beginning. If you'll see the history and examination, you did few silly mistakes. I think which usually examiner don't take. Now, Dr. Kala asked you about the like you said ki ulcerative colitis. You said constipation is rare. Then he asked you again. Then you said the constipation alternate with diarrhea, which is the feature of ulcerative colitis. I think these are very silly mistakes. And sometimes then when Dr. Kala asked you about the examination, and you said between which is better, colonoscopy versus your rectal distal rectal examination, you stuck there. I think these are very silly mistakes which usually examiner don't take very positively, and just reading at trials and giving very fine figures for of recurrence in different trials. If you will not cross that border, it's very difficult to reach on the trials. So I think you have to build on these things. The clinical examination you cannot skip, and that's very important.
Yeah, there are good inputs, of course. Since this is a initial presentation, not so experienced, we didn't harp on those points because there only the examiner will start pulling your legs and you'll be into the trouble. No doubt, we purposefully skipped that one because that was a not such a good answer to give. I would say that was not at all a good mark fetching answer. So I think this discussion must have helped you in purifying your presentations. Later on, do remember all these things, and during the examination, this is a fixed thing. In the examination, the timing is not fixed. They can pull you or distract you anywhere they find you loophole and proceed. And so, with those input of yours, thank you, Kalai, and thank you, Hriday, for starting this discussions or courses. One point for all of us and for the PG students, whoever are presenting, please do not mention the name or identification of the patient on the imaging because in one or two forum we have landed up in serious trouble with this. So just avoid the name mentioning. Kalai, you want some closing points?
Yes, we have shared feedback. So I think probably maybe it's your habit. You try to answer quite fast. I think speak fast. So sometimes, yeah, it's okay. I think each student have their own method of answering. But just think about it because sometimes you can make more mistakes when you try to answer quite fast. So just maybe a pause for a second before you giving the answer should help you.
So with that,
Dr.
can we
Kalai,
close now? Yes.
thank you, both of you. And I think Dr. Vaibhav is there. Vaibhav, you want to say something?
No, sir, it's okay. It's a good discussion, sir, and it's also learning for all of us, sir. Thank you so much.
Hey,
I
Vaibhav,
think
you are there?
Yes, sir, I was there, sir. I was
Oh,
listening.
it
Internal
was
exam.
nice. I think it was brief, right? I think and I think next session is by Jipmar Pondicherry, Dr. Kalai,
Okay, sir.
on operative techniques, and that will be moderated by Dr. T.D. Yadav and myself. And second session of FIB will be by AIMS Patna on post-operative scenario. That will be moderated by Professor Anu Bihari and Dr. Vaibhav Vasne. And I'll be adding one more moderator to each session. I'll circulate the list. And thanks a lot to all. Thanks, Vaibhav and your team for hard work. Thanks, Dr. Kalai and Das sir and Dr. Harjeet for joining and moderating and giving your inputs. I think that will help. This session, I think this program is meant to basic to train resident, and if you want to commit mistake here so that we can avoid mistakes in the examination. This is the rehearsal for your examination. That is the main aim of this listing program. Thanks a lot. I think
Thank you. All the best who presented well, and just learn from it. Nothing to be worried about your presentation or our responses. Thank you all. Thank you, Kalai.
Yeah, thank you, sir.
Thank you.
Bye.
Thank you, sir. Thank you.